So this is the Clinical Consultation Network. Dr. Vaught, we do this every week at 12:30 Central Time, and I want to roll out the welcome back for you to join us anytime you would like.
Thank you.
You're very happy to have you here as a guest. Dr. Vaught, I'm going to let her introduce herself in just a minute after I do the Get Smarticle for today. But she has been working with our department for a very long time. She's a neuropsychologist and has done tons of consultations. In fact, if you've worked with people in our system, you've probably seen some of her reports that she's done in the past out there. So we're very happy to have Dr. Susan Vaught here as our guest today. Before I let you introduce yourself, Dr. Vaught, I'm going to go through a quick what we call a Get Smarticle on here. We just started doing this last week. And so what I do is just pick an article that has a kind of a loose relationship to whatever's being discussed that day. Maybe it doesn't have any relationship to what we're discussing that day, but in this occasion, it has a little bit of a connection because you're going to be talking about borderline personality disorder. And the Get Smarticle is about structural MRI brain alterations in borderline personality disorder and bipolar disorder. I'm going to focus in this little quick review primarily on those changes that occur for people with borderline personality disorder. I'm sure as you go through your presentation, you're probably going to be able to add to some of what's discussed here. But the article is Structural MRI Brain Alterations in Borderline Personality Disorder and Bipolar Disorder. It's what you call a meta-analysis, essentially. So this was based on a PubMed literature search for related articles about MRI structural imaging, bipolar disorder, and borderline personality disorder. The inclusion criteria in this study was they only reviewed human studies. They looked at articles only that had been published since 2011 and that were published in English. They ended up with an analysis of 20 articles in this particular review. Just a quick review of some of the brain structures involved here. So we have this thing called the limbic system. And there is in that limbic system, the amygdala, which controls a lot of your anxiety and emotion. So your emotion regulation comes from this part of the brain. The hippocampus, which is the seat of memory for people. And I'm careful about talking about function. These are hypothesized functions. They are researched functions, but they're sometimes you can go a little bit too far in talking about this. But these are important parts of the brain. You also have the hypothalamus, which basically regulates a lot of the functions of the body, like temperature, hunger, food, fight, flight, all of these types of things are wrapped up there. And then you have up here the cortex, which is basically the thinking part of your brain. And you have gray matter, which is basically controls a lot of your cognitive processes. And then you have white matter that really connects the pieces of your brain so that you're able to put two and two together, so to speak. Also want to mention the insula because this is a top section of the brain. So you're looking down on top of the head here to see this cross section of the brain. But I wanted to mention that because it is implicated in some of the effects of borderline personality disorder. So the insula is this area around the right and left ventricles. You can correct me if I'm misstating any of this, Dr. Vaught. And so looking at some of the structural findings and functional implications of this. So in this study, what they found, so by looking at these 20 studies, they put together a list of different outcomes. One of the things they found was that borderline personality disorder patients had a smaller amygdala than healthy people. I'm a little careful about how far to extend that with regard to functional implications, but the amygdala generally manages fear and anxiety. And so, those are a couple of things to consider. Volume reductions occurred in both borderline personality disorder and bipolar disorder in the hippocampus and in the gray matter and the white matter. So I mentioned that hippocampus is primary consolidator of memories. It also assists somewhat in navigation. Gray matter, information processing, white matter, connecting communication between different parts of the brain. So those, now, whether or not a volume reduction means that those functions are affected, that was not part of this study. So I want to be careful to say that, but these are, potential outcomes of that. Changes in the left insula were associated with suicide attempts in borderline personality disorder. So that part of the brain that I showed you around the left and right ventricles, the insula, is, changes in that were associated with suicide attempts. Reduced cortical thickness in bipolar disorder was related to multiple manic episodes. So as there was a reduced depth of that cortex, so that gray matter that I showed you, that was related to multiple manic episodes. And the latter two findings, this, one of the problems I think that you see both with bipolar disorder and borderline personality disorder is that they may be progressive. So in other words, the longer the person experiences this disorder, the worse these changes in the brain get. So Dr. Vaught, I don't know, you may want to comment a little bit on this study. It's just a study that was done back in 2011 on brain function. I know you're going to talk more about behavioral implications of bipolar or borderline personality disorder, but I don't know. You're a neuropsychologist, so I wondered, do you have any comment about this article and any other thoughts that you may have there?
I think most neuropsychologists who work in SMI settings have known for years that people with borderline personality disorder, there's some cognitive dulling, much as you see in people who are aging with schizophrenia. After a certain point, you see some cognitive dulling in that population. And with borderline personality disorder, especially with the higher levels of acting out, you do see some burning out or dulling of behavioral issues in the mid 40s. And that is associated with changes on neuropsych testing that would suggest that memory and some other sensory sorts of things are deteriorating a little bit. It doesn't necessarily look very sharp or keep going, much like the population with schizophrenia, where they truck along at a certain level, and then all of a sudden in their 50s have a sudden drop into sort of a dementia praecox that, an early state that's associated with schizophrenia has to do with sort of enhanced frontal shriveling up that has been going on all along, but then just really accelerates. And then it just sort of stops and they level off at that point for a good long time. It's a similar sort of function, but maybe with different areas of the brain. In trying to come up with models, we wondered if the overuse of the limbic response or the overfiring of the limbic response produced some gradual inability for the limbic system to muster itself as they age. So that was kind of our working theory. It's much like with trauma patients, there changes in the brain over time, and that system keeps firing off at a high level. So
where you had difficulty with emotion regulation, that could get even worse over the course of time.
And I'm not a geneticist, so forgive my inelegance on this point, but bipolar disorder, especially that more classical type where you see the very large-bodied males, especially with more manic presentation, has its origin on chromosome 15, and the adjacent area is Prader-Willi's responsible. So I've always found that interesting, also that those seem to be related in their own way. But what?
Yeah, so before you launch in, look, I want you to introduce yourself just a little bit and let everybody know a little bit of who you are and like what your background and experience is. And also, I hope Pierre, my co-host today, shared with you that we wanted you to share an interesting fact with us. And so So can you tell us a little bit about yourself before we get into the feature presentation?
Sure. I'm licensed in Tennessee and Kentucky. I'm an odd duck because I have a clinical degree that's both clinical psychology and also intellectual disabilities research from the Kennedy Center. So I literally have a PhD in IDD. But I have all my life had an interest in the area and kind of worked in that crossover between SMI, IDD, neuropsych. By profession, I'm a neuropsychologist, and that kind of all blends together for me. I've been in practice almost 31 years now. I've been up in Kentucky for the last 11 of those, though. Um, Dedicated souls like Pierre hunt me down occasionally and ask me to come back to Tennessee and do stuff. And Katie, God bless her, down at
Yeah,
Development Services at Dixon, always comes and gets me when she has questions as well. So I still cross over. Back in the day when Elizabeth Gerlach was around, those of you old enough to remember her, she wrote me into y'all's waiver. I mean, literally, there was a point where there was the waiver existed, and then there was a payment specifically to me that was written into that waiver for doing IDD evaluations. So,
and even after all these years, we still have that contract with you. So we
yeah,
were able to
it's still
utilize
there.
the,
She was real determined that she'd be able to use my services when she wanted them. So I came up here and I now work in a old haunted psychiatric hospital that's been around for 165 plus years. So it's its own character in my life, but I do write books for my relaxation. I write mostly for young adults and more lately the last few years from middle grade. So the younger kids and primarily now mysteries. I used to be a little more diverse, but I've kind of honed in on the mysteries and I've last couple of 2 or 3 years, I've won some Edgar Awards. So it's kind of given me a little niche in that world. And I tend to write mysteries for kids. Almost all of my characters have mental health issues or have some neurodivergence. So I try to just show them out living their best lives, not making that the focus of the book, but the main character might have that as one of the things that they're dealing with. So
seems like that's a great way to get messages across to kids about different things they might be experiencing through their mental health disorders if they're reading these books.
yeah, I hope so. And I hope it, some of the adults working with them too. The one I'm working on right now, the kids are actually using skill system. So I would love children to know that that's out there for themselves if they want to try it. So,
Well, that's great stuff, Dr. Vaught. Really appreciate you. Uh, that is a very special fact. I'm very impressed with the number of books that you've written. How many have you written?
I think I'm at like for kids, I'm like 14. I've got about 6 or 10 or so under a grown-up pseudonym that I won't mention because it bought my house. But yeah, that those two don't ever need to mix because the books I write under the grown-up pseudonym, yeah, no, they're not for kids,
Yeah.
but they do pay a little bit better. So.
Well, all right. That's really cool. Thank you for sharing that. And of course, you in your typical life here, you're a neuropsychologist and you've worked a lot with people with borderline personality disorder. So you've got a presentation to share.
Right. Up here in Kentucky, the service system is got some similarities to y'all, but it's also very radically different in a lot of ways. The state hospital is still a thing up here in terms of there's a handful of private psych units that have about 10 beds in our catchment area, but essentially we are the only psych hospital in town. So we get everything from the distressed banker whose wife left him to the SMI piece. So we are a full functioning psych hospital, but we don't function anything, I don't think, like the psych hospitals in Tennessee that are more limited by your gatekeeping system. We have a gatekeeping system that gets roundly ignored by a lot of folks. And there's been enough times that our director's been snatched off a golf course on a contempt warrant that basically we're under the instruction if the patient shows up with a court order written on a napkin, we're to admit them and ask questions later. So we still get we don't have the limitations I don't think that the Tennessee system does. Now we are very limited in beds. So we can't, fill up and stuff like that. But the IDD system also has some similarities and differences. But there's sort of some missing components that the psych hospital ends up filling. When I first came here, there were a lot of patients with, whether you want to call it borderline personality disorder or behavioral dysregulation, who essentially lived at my hospital, even though they weren't supposed to.
Yeah.
And I put a stop to that. So if I ever need nursing home services or IDD services, please get me out of the state of Kentucky, because I'll just be murdered if I'm putting a program here. But we've been
Explain
working.
a little bit about that, Dr. Vaught. What's your concern with having people with borderline personality disorder?
I don't mind having people with borderline personality disorder at the hospital. I mind having people with borderline personality disorder living at the hospital,
Yeah, yeah,
especially if they're IDD, because we have no habilitative programming and they lose skills. So they'll sit up here and get less and less able to function in the world, number one. Number two, we don't have access to any of the deinstitutionalization resources that the ICFIDs have. So if they get sort of that institutional dependence or institutionalization, we're an acute care psych facility. I have no ability to do a prolonged discharge process that would help them integrate into the community. So it sets them up for failure. And also, at least initially, although that's changed now, because it was a psych hospital, they weren't eligible for that high level of funding that they would get coming out of the ICF. So basically, we'd be coming to who here has a program? These names? Anybody from like a IDD, SCL? I don't know what y'all call them there anymore. The homes where people live.
supported living.
Yeah.
So what?
Yeah. Do you have some supported living folks here?
Oh, yeah, well, we've got people all over the map.
So, I mean, in this meeting, because basically what it was putting me in the position of having to go to these supported living folks and say, hey, would you please take this acting out IDD patient from the state psych hospital for the same amount of funding that you'll get from somebody coming from home? That didn't go well. And they ended up stuck here for a long period of time, and they just didn't have a good quality of life. And so it took us a lot to reverse that. So now what we've got is four really good IDD liaisons. My community mental health centers work really closely with me. We have a lot of functioning cross-system crisis plans across the region. And most of our patients with behavioral dysregulation are managed in that fashion, and we function as the safety net. So when the cross-system crisis plan fails, the patient is brought here to give the team time to get something set up, get to have time to meet, retool, possibly repair an environment if needed. And then, we work with them. We have the cross system plans on paper, and I've gotten my psychiatrist to buy into it for the most part, unless I get a locum tenens doc who's nutty or something. They buy into it and they support the community. So now our community players are much more willing to take a risk
Yeah.
on difficult clients because they know we have their back. They know we are here. We'll consult with them. They can have meetings with us anytime, about stuff. So we're right with them on this process. We also brought the concept of sort of DBT based supports into the service system up here and introduced skill system. And Julie Brown hangs out here sometimes.
Okay.
And so
Yeah.
she's been very helpful to us.
Julie's been a guest on CCM before, and we're probably getting close to needing to have her back again. But the thing I was going to ask you about your team, though, so how's your team composed, and how many people are on your team?
You mean at the hospital?
Yeah, yeah. So you were
I
talking
have
about
14 people in my department as psychologists. We have kind of a service or unit model, so they serve different units in the hospital. I have two others that are pretty IDD aware. One's Marie Lavasse, that she works up here
oh
now.
yeah, Marie. Tell her hello.
And the other is Dr.
I
Kristen.
actually thought about her today and was going to mention she was a great. She's LPC, right? Licensed professional
She's
counselor.
master's level in Tennessee. She's independent. Kentucky, they didn't recognize her 20 years of independence in Tennessee, so she's still working on the independent licensure up here. She's a little bit more behavioral oriented, strict behavior oriented than I am, and so she's a better plan writer and a better trainer for people on behavior plans. And she probably is a much better practitioner of DBT than I am. I've had training in it and then a lot of training in skill system, but it's not what I do. I'm primarily neuropsych. So what I look at things usually when people like Pierre call me is try to look at meta level problems, like where are the challenges in serving this individual? Because what my experience is kind of being the mediator between all the different pieces of various service systems is that the community is often coming to a specialist or to Bruce or to us, and they're like, our house is on fire, our house is on fire. And basically we have a bad habit of going, okay, here's a cup of water. We need to do much better
Yeah.
than that
Uh,
because it sort of erases our credibility and it makes, all service systems are really designed to communicate top to bottom. They're not designed to communicate left to right with each other. And so you really have to work to get that communication going and then preserve it and then codify it so that, when COVID takes you out for a month, it doesn't all go to heck while you're not looking. So that's kind of where we are. We're at the point where we're starting to look at how to codify some of what we do in terms of cooperation. I will say that the best asset we've gotten in the last 10 years up here has been a mental health court in one of our regions because that has tremendously improved communication and we're managing much more difficult persons in the community in that region than we are in other regions and managing to do it without assaults and burning placements down and stuff like that. So probably the one area that we're still struggling the most with is sexually dangerous individuals and people who swallow stuff, which, I think is typical across the board.
yeah,
So,
no, we all struggle with those situations, and it is challenging here in Tennessee, as you know, because we have very little institutional care here at
yes,
all. We do have ICFs, and we have about maybe about 900 people in those, and then we have Harold Jordan Center, and then beyond that, we're pretty much community focused at this juncture, and so we're facing some of these same challenges you're talking
yeah.
about.
We have very little institutional care for anybody with an IQ over 50. The way that the law is written up here, and it was written this way to get justice out of Kentucky, is that they're not eligible for ICF referral or placement if they are mild or severe. So only, I mean, mild or profound. So only moderate to severe individuals, a very limited IQ range, can actually go to the ICFs here. And that rules out most of the people who are acting out at this type of level, because most of
Right.
those are 55 to 68 crowd, for the most part. Sometimes not, but for the most part. So we don't have any institutional options for those, and most of them are not legally competent to stand trial. So justice is also not an option. And so then here you sit, you know. And I
Right.
know in Tennessee, if y'all try to hospitalize those at your state hospitals, you probably get laughed at a little bit more than you would here, because if I remember, it takes an act of God or Congress to get somebody in one of your state hospitals, where here,
Yeah.
if you take your girlfriend off and say something crosswise, they might bring you to me for 3 days at least. So,
Yeah, we're in a circumstance where our state hospitals are only admitting people who don't have insurance, which, the people in our service system are all people who do have insurance. So we've
right.
been pretty well relegated to utilizing private hospitals uh, when when we need that. I don't know if you've heard much about the assessment and stabilization teams that we've been developing. Uh,
Yes.
they're
Heard about
now have now started work, but part of our goal here is to try to right size and make sure people get a hospitalization when that's what's needed, and then to prevent them when it's not needed. And so, that's in large part what we're trying to accomplish currently.
So what my presentation is today is kind of it's some things I pulled out of other presentations I do up here, but it's kind of designed for service providers. So I'm hoping that's mostly what I've got, people like Pierre and Bruce, and I don't know a lot of you other folks, but I'm hoping it'll be helpful.
Yeah.
It's also,
Good.
I hope, has a couple of things in there that might help you educate staff and like law enforcement and things like that, because law enforcement tends to want to back way away from all these situations, and that's not always the best option. They either want to get too involved or they want to back too far away. They don't know how to kind of work in concert, and that's been a real key piece because I assume your system is similar to ours in that we cannot compel squat here at the hospital or out in the community or anything. The only people that can compel somebody to do something against their will is the court system. And so we need them in some cases to not depart the situation, but to work with us sort of hand in hand for everybody's safety. But that's not always easy because they tend to be black and white thinkers. They either think somebody is theirs or they don't. And again, that top to bottom's communication, but not necessarily the side to side. So I was going to go ahead and try to figure out how to
Yeah.
share this and then see if I can do it again like I did before. Okay, am I successful?
You're successful. You're up.
All right, so I stole Julie's lingo. First I said DBT based, but then I went back to DBT informed, which is, Julie Brown's way of, noting that her skill system is DBT informed, meaning it uses those principles. And one of the points that I'll make later on in the presentation is the reason why we keep going back to it is it's the only evidence-based practice that shows any benefit at all in reducing self-harmful behavior in people who present like this. And so trying to figure out how to make it work in our various service systems becomes a challenge. So again, behavior related to acute psychiatric symptoms, or SMI, which is what I do every day. Really, when you try to do behavioral analysis, there's not discernible goals for that behavior. It's not easily amenable to functional analysis. The only function of the behavior is often response to internal stimuli or symptoms, or relief from the internal stimuli or symptoms. So you can't find much more in the way of ABCs with hallucinations, for example. And there is no light switch. If they pick that person up hallucinating and screaming and pounding on staff at their program, then they hallucinate, scream, and pound on the police on the way over here. They hallucinate and scream all the way up my elevator, and hallucinate and scream all the way over to my unit until we get them medicated, and continue to hallucinate and scream until we get them treated appropriately. So the behavior doesn't change across time and environments until you apply the appropriate intervention, which is often heavily pharmacological. Also, treating things like UTI and dehydration, which have developed during the episode. So in the absence of sudden trauma, illness, environmental change, with mental health stuff, you often see people stay stable for longer periods of time and then kind of falling apart slowly in a more predictable fashion with a gradual rise in those recognizable symptoms. So if you're dealing with dysregulation, behavioral personality disorder, you can discern the goals for the behavior. You can identify through the functional analysis, through underlying emotional goals, things like that. It's sometimes tough with personality disorders, especially if you haven't done a lot of reading on borderline personality disorder to get at the emotional goal. And it can sneak by you if you don't do some reading on that. So it does have a light switch. It is not consistent across time, environments, and situations. And everybody in the situation who's a practitioner can pretty much tell you that that person has some volitional control over their symptoms. They choose when to express them and when not to some extent. Not always totally, but for the most part. And the confusing thing is the symptoms will respond to medications in the short term for that moment. And they'll stabilize for a very brief period, but without extensive environmental and behavioral interventions, you'll rapidly be back in the situation that you were before. So in the moment, if I tranquilize anybody, I can stop some of what they're doing
We can
for as long as I can keep them tranquilized.
if we can know people enough, they will not behave in bad ways.
I guarantee you, if any of you show up
unfortunately,
acting out here, I can make you stop acting out in a minute.
yeah,
You might
we just
also have
have
difficulty
one
believing, but you
medication
will
on
be
top
able
of
to do it. So,
another,
yeah.
Yeah, so we've seen that phenomenon. Yep.
Yeah. Also, after a point, people get habituated. This is a terrifying looking building. It is an old, literally 200-year-old psych hospital with 7-foot stone walls and metal doors. And so, we have the old fashioned restraints and all that kind of stuff. We've kind of moved to the restraint chair, but, a lot of times we're getting people in high on meth, screaming, yelling, trying to kill us, standing up and walking with our restraint chair, that sort of thing. So we have lots of methods to get you to quit doing that. And most people will habituate to the fact that if they've been here more than once, that they only really get to assault people one time before they visit that restraint chair, you know. And so they quickly, if they have any volitional control over the behavior or not, it stops. If they don't, then it continues, and that does tell you something. So hold on a second here. So here's the kind of flow chart I came up with to try to help the law enforcement people understand that with a true psychiatric presentation, we need high structure medication, hospitalization when they're in crisis, and then increasing the community support to wrap around them. And our goal is we want the police to kind of get out of our way unless we need some help compelling them to adhere to treatment, to modify supports to accommodate additional disability that happens every time these people have psychotic or manic episodes. There's a little bit more debility that gets involved, and the longer they stay out there untreated, the harder it is to pull them back. They get a gradual return to baseline, and then your goal is maintaining the baseline. So that's how we want them to look at the psychiatric situations. But For the behavioral personality disorder, and I would add in maybe primary substance abuse here, we do want the high structure behavioral intervention, environmental restructuring through that cross-system crisis planning, short stay hospitalizations when that plan fails to allow for modification safety. We need consequences for their actions and focus on personal responsibility and medication only if needed. So in this situation, we do not necessarily want them to decriminalize. We want to use legal involvement to mandate and incentivize modification of behavior. Sometimes too, to incentivize the modification and change in behavior of caregivers, or, if there's somebody that's doing something radically dangerous in the community and you've got one piece of the community that's reinforcing that and they're refusing to change their behavior, then sometimes the angry judge can help you with that as much as they can help you with the adherence. But always be careful with angry judges. Accountability, personal responsibility. We want a new baseline with improvement over time in these situations. You must, with appropriate treatment, personality disorder, although it's refractory, it can improve. So unlike schizophrenia, where I can treat your hallucinations, but I can't make them go away, in personality disorder, theoretically, we can help with new coping skills and the behavior may actually resolve. So
Just a quick question here, Dr. Vaught. How have you been able to engage the court system in Kentucky? Tell us more about how you've been able to. You mentioned that you have a mental health court, so that's somebody you can work with.
Mental health court makes everything wonderful. But how I originally engaged the court system was actually, it sort of engaged us because a judge up in a little tiny town in Region 1, about 3.5 hours from here, got really angry over a case in his area. And he subpoenaed, God, all the archangels and everybody else to his chamber in this little tiny field in the middle of nowhere, Kentucky. They included the commissioner, me. He wanted 2 representatives from Western state. And all of it was to explain to him why he could not put this man with mild intellectual disability who was causing trouble in his community in one of the ICFs. And he kept us there for an entire week. And this is where I opened my mouth and said the words cross-system crisis planning. So at the time, we have a state guardianship system, which is a fully staffed state guardianship thing that you guys don't have as much as we do. It's a very active service up here. So we had state guardianship, IDD, we had the local community mental health centers, police, fire, local hospital, and us were all there. And he finally came to understand that he couldn't send the person to the ICF. And so he said, well, what are we supposed to do? There's no other option. And I stupidly at that point in time said, oh, wait, but there's this thing that Bruce Davis taught me about called cross systems crisis planning. And he asked for an explanation, which I gave it to him. And it was, at that point in time, it was like a Wednesday at like 3 or 4 o'clock. And he looked up and he said, okay, fine. I want one by Friday at 3 o'clock.
Okay.
And he left.
Well,
and
I appreciate the shout out there, but I'm going to have to pass that on back to Start. Who we're using for our training where I learned about cross-system crisis.
The first cross-system plan up here was developed between that Wednesday and that Friday. And when the local hospital tried to whine about it and local fire tried to whine about it, he just court ordered them to comply. And it ended up over time, it worked. This man went from 30 hospitalizations and like 22 arrests in the previous year to 1 hospitalization, I think 2 arrests. And we had a program set up for him that was functional, and I haven't seen him in 7 years now. So, we're really improving on that front with him. But we did learn that it's better to involve the angry judge on the back end of things and maybe not have him court order so much, because in that particular instance, if you wanted to change a medication, you had to go back to court. He was done. He was just through with it. And so the rural judges kind of pushed it. And so once that had some success and he started talking about it at the judges' school where they all go for their yearly training, then I got calls from other judges saying, so, that thing that you did over in Region 1, how do we do that here? Or how can we do that in? And so then kicking, screaming, whining, and moaning, all 4 regions got on board. The other state hospitals have not so much, and the judges in Louisville or Lexington have not decided to push the issue yet, but it's probably coming at some point in time.
Collaboration with the courts, though, is so important, because sometimes that's the accountability piece that you need to go along with everything else.
Exactly. So anyways, one of the debates everybody gets into is, do they, can a person with intellectual disability have a personality disorder? If so, at what level of IQ? And I try to stay out of that debate. I mean, my personal opinion is yes, they absolutely can, but I'm not sure that it matters. Once they're in your service system and you are responsible for them, what matters is that dysregulation and safety. And so that's where I try to keep the focus, not what we're calling it, but what we need to do about it. Again, when they come to me and tell me my house is on fire, I want to give them more than a cup of water. Like, oh, here's the label for it, and here's why it's happening. Well, good. What do I do about it? Is what they want
Yeah.
to know. And so, um, basically, I want to just kind of focus on dysregulation and the things we can do about that. So here are the issues that we run into that I think need to be discussed and debated, and the things that may help you identify the cases who need this kind of approach in your service system. So the first thing you encounter is you get their record and they have 49 different diagnoses that run the gamut, and the poor parents, if they're at home. My son has bipolar, schizophrenia, ADHD. They try to run it all together like a single sentence, and it's a nightmare. And that then prompts every single treating provider coming on board to be confused and to you get clouded behavioral and pharmacological approaches, non-parsimonious treatment goals all over the place, and you get the record of their, disorders that's about that thick, and it doesn't help anyone. So,
Dr. Cheatham, who used to be our medical director, said they will have 12 diagnoses, and if you're lucky, one of them might be correct.
right, right. The next thing you see is frequent medication changes or requests for medication changes as very desperate caregivers, understandably desperate, seek that ever elusive magic bullet to stop this. You get a clear pattern of responding to the medication only during the sedation effect period for that med. Then you get the corollary too of the people taking the person to the doctor or the program seeking the doctor's support in a moment. So he'll get anecdotal reports of the situation instead of actual behavioral data, and then make decisions based on the emotion of the moment because that's all he has or she has, not the data pattern over time. And that becomes problematic. So you get then the gradual drift towards treating some sort of unspecified psychotic disorder, or other vague psychiatric labels instead of a bullet-like focus on improving impulse control so that behavioral tactics, and behavioral specialists can do their thing. Um, Trying to add a little time between impulse and action is often the most effective strategy here, to allow our behavioral interventions to work. So you want to work on emotional reactivity and impulse control, but invariably somebody will, especially if they've been hospitalized 39 times, they'll report hallucinations, even if they don't show you hallucinations, all that kind of stuff. Or some doctor asks them a yes or no question and they answer, yes, sure. You know, like a lot of our IDD folks will tell you yes to 80% of the yes, no questions you ask. Do you see pink elephants? Do you want to kill your staff? And so then, you don't really get a clear picture of what you're treating. And then you have system rules and regulations, which focus more on freedoms without equal balance of responsibility, and rights without responsibilities creates perpetual 14-year-olds. And I think we're dealing with a lot of those in our service system. We're kind of emotionally, societally functioning between a 13-year-old and a 15-year-old, where they have all the rights in the universe and absolutely no responsibilities. And that is a bad combination. A lot of times for a lot of folks, one without the other doesn't lead to the type of behavior that you want. Least restrictive environment gets pushed towards a one size fits all rights versus individualized to patients. And excuse me for using the word patient because I know y'all don't, but we did a survey here and that's what ours want to be called. So we still use the word patient. So, but it's not individualized to their level of risk to self and community. And I've had to make this argument up here to IDD more than once that the least restrictive environment for somebody who's repeatedly trying to kill themselves is radically different than the least restrictive environment for someone who is not trying to kill themselves.
Yeah,
So the
person
least,
takes,
if you
it has to be truly person.
So it's an individualized concept, but people forget to make that argument when they're writing a behavioral structure that, okay, based on this person's risk to themselves and to society, again, your patient with a predilection for 5-year-olds sexually is going to need a different type of environment than your patient who has an age appropriate fixation on their own age group. And even then, less restrictive environment for a person who is more normative in their sexual behavior and doesn't try to force themselves on people. And the oopses in those situations are not tolerable. I mean, you can't, oops, I'm sorry that 5-year-old got raped. That is not a thing, that's not an acceptable outcome.
And these changes don't have to mean that the person lives a completely horrible life. It just means that you've got to really, to live a good life, you've got to have these types of limits in place.
Exactly. Their least restrictive environment is different. And if you've got a chronically suicidal patient, one of your goals is to keep them alive, then their least restrictive environment may have to not include the things that they try to die with. So, also, these are high resource utilizers with high cost to caregivers and multiple service systems. We've actually, I think I saw before I went into this thing where I can't see chat at all, somebody ask about funding. Y'all are different. We still have a traditional waiver funding source here, and it's different levels, tiers of funding. But we have some unusual stuff too, because when service systems get worn out enough, they'll kick in money, especially in the rural areas. Like we've had a couple of rural hospitals that have offered to do something financially, and they've helped us with a cross systems plan on somebody who was wearing out their emergency service system, because it was just we had this one guy that, every time he said he had chest pains, they were obligated to call an ambulance, take him to the hospital until we figured out how to get around that. So I mean, literally had 41 visits in 3 weeks, and EMS was like, we just can't keep doing this. So that brings them to the table a lot. But a single borderline patient or a patient with severe dysregulation can bankrupt the service system if you are not careful about how you deal with that high resource utilization if you don't get all the players to the table. But it's not just your service system that's getting bankrupted, so don't leave those other people out there that are being affected. Consider all the other service systems that are being worn out by this and bring them to the table, and they might give manpower and money too. So sometimes we get some atypical funding streams going on some of these plans. And again, too, angry judges can order people to do lots of stuff, so you can be surprised. The rural judges, I don't know about in Tennessee, but rural judges in Kentucky are very powerful human beings, and once they order something, it's really hard to undo it, especially if they write it a certain way that says another judge can't undo it and then retire, which we've had happen twice now. There's a high potential for staff conflict splitting, frequent investigations, pulls from care, rapid turnover. So I think everybody that has worked with these patients understands the staffing burden. And that's often the first way you've got a patient like this, is because your staff is actually trying to kill each other. They're yelling at each other over how they do stuff, or this one's not following the plan, or, because these patients are pretty crafty. They'll talk Bruce into a cookie, and then they come tell me, why don't you give me a cookie? Bruce did. And then I'm coming after Bruce because he made my life miserable, so, there's a lot of stuff that goes on this way that has to be dealt with. And the patients are at actually higher risk for abuse and assault. They will find that button and they will push that specific button in a staff member until they push somebody over the edge, and they'll get popped in the face or yelled at or restricted in a way that they shouldn't. And then the patient is dealing with that trauma, the staff is dealing with their issues, and the program has the abuse tag, and it's just kind of a nightmare if you don't set it up correctly. And even set up correctly, that's still an ongoing issue. And the other problem is, if you just try to apply traditional behavioral supports like you always use in these situations, you get invalidating environments and you get a rapid deterioration in patient caregiver or safety. And I think that's where Pierre and I started communicating, is I said something like that, and then I think they decided to use a traditional behavioral approach on the patient I was consulting with, and it went bad quickly. Am I correct on that, Pierre? Making him talk.
That's correct. You're correct.
Because I got a quick call back. It's like, so can we talk about this invalidating environment thing again, and maybe change some stuff, because that usually doesn't work with this type of patient. And it's not, please don't hear me saying anything crosswise about, operant behavioral supports, because they're really, really good. ABA, and nothing I'm saying here is contradictory. It's just that they need some
Right.
other stuff too.
It's when it's applied to the wrong situation. That's
Yes.
it, which is true of any clinical treatment that we talk about. So that's where getting down to what you're dealing with is so important. One of the other things, Dr. Vaught, that is really critical about this too, is you're focusing on such smaller details of how someone responds to things. I was just thinking about someone that I've worked with borderline personality disorder in the past, it was not so much an overt, very identifiable behavior, but it was more subtle things that you would notice in how the person reacts to having limits set or other things of that nature. You just see a change in their facial expression and a turning away and an inability to continue communicating with people effectively. And, this was a precursor to emotional dysregulation for the person. And
Yes.
so you're looking at a series of very small things in this, which I think behavior analysts can actually help with, but you've got to get down to those details and how someone
You got to find all the links in that chain and figure out where you can disrupt it. Staff who care for people with these issues are in life or death struggles with these people every day. And we tend to overburden them with types of data collection and facility paperwork. And this is not the wisest choice. That's how people swallow stuff and die. It's how people run out in traffic. When you divert when you have an overtly suicidal or self-harmful individual who is actively attempting to hurt themselves or other people, and you divert staff's attention to anything else, you're setting everyone up for failure. And that's a challenge, working with this population. So vigilance fatigue is real. So one of the things we've kind of gotten into is trying to shorter shift these folks and rotate their staff more frequently because they get tired, and you can only stare at something so long before you stop seeing things or before you literally wear out doing a one-to-one. We rotate our one-to-ones to the hospital every hour. I know it's not always possible in the community, but I mean, it's a real thing. And military, there's a lot of literature on vigilance fatigue. You can get a lot out of that. And team communication has to be increased to levels from the outside that seem almost absurd to support your staff, prevent burnout, stay focused on gains, reduce splitting. Trust becomes very quickly an issue with your team. And the team fissures and fractures that existed prior to this person showing up in the environment are going to be more obvious to you. I'm not the most social human being outside of work anyways. And so having to talk to people at the level all the time, every day, it gets tiring. It does. But if you don't keep your communication open, then who is running your program will be that dysregulated individual and not you. So invalidating environments technically is an environment where communication of private experiences gets sort of unpredictable or extreme responses. And you can see that easily. So person A picks up something and cuts their arm. Staff member A will respond one way, B another, C a third, emergency room, so they get very inconsistent responses. And emotional experiences get rejected, ignored, judged, dismissed, or punished. Why did you cut yourself? That wasn't that serious. I don't know why you should be so upset about that. They hear all those messages, but the problem is they still have that gigantic emotion and no resolution for it. So it doesn't really help them come up with a strategy on how to do something different. So the ways that we create and maintain these invalidating environments in IDD services, because of the nature of how our regs work as a rule, we write plans on responses to behavior where we put life-threatening behavior on par with anything else. So suicide attempts and making false allegations are really not in the same ballpark. Also, the thing that pisses mom off, I don't want this person to drink. I don't want this person to do that. The other, again, not on par with suicidal behavior. And in order to kind of get this point across, I ask you all to think about your own children or your spouse or someone who is dear to you. And if that person walked up to you and self-harmed in front of you or attempted to kill themselves, would you have an emotional response to that? I'd like to hope that you would.
I should think so.
And I would like to hope that that response would be different than the response that you have if they disagreed with you about going to a certain place for dinner. But we'll write our plans to where anything in this little table receives this reward or this benefit. And so we end up devaluing life, both for them and for ourselves. We get used to viewing it on par, and it isn't on par. It is a big deal, and it has to be treated as a big deal. We write plans and responses that specify an acceptable amount of life-threatening behavior. More than once, I've reviewed plans here where it's like, person will attempt suicide only 5 times instead of 15. I was like, I get that. That is how you're taught to do behavioral stuff. But the only acceptable amount of hurting someone else or yourself is 0. And if we put anything else in the plan, we are creating that invalidating environment and basically telling a person with this personality build, your life and your safety and your welfare do not matter, or matters very little. And you lie to patients. You all do it, and you've all done it about your own emotional state when any normal human being would be feeling homicidal, and your face looks like this. So, the patient has just finished trying to beat their head against the wall for 15 minutes, and they finally stop. And their first question to you is, "Are you mad at me?" And you're looking like dude in the middle with the red face. You're like, "No, I'm not mad." You know,
Yeah.
you know, it doesn't take a lot of IQ points to know that that is horse hockey, but also if somebody just finished trying to bang their head for 15 minutes and you've exhausted yourself, stopping them, you might have any number of emotions. And so a more accurate response would either be, "I don't really want to talk to you about how I'm feeling right now because you're engaging in a lot of unsafe behavior and that can't be our focus. I don't want to share with you, whatever reason." Or, "Yeah, I'm pretty mad, but I still care and I'm still going to help you. And so, but we every time we do that, every time it's not abusive to tell the patient the truth as long as you're not abusive in the way that you do it. And so I just strongly want to encourage you when you're doing your line staff training, they go and ask those questions because they know that you're angry. They know they have jeopardized that relationship and they need some sort of they're trying to reconnect at that point, and just not telling them the truth, it just skews their reality all that much further. Um, there are a lot of other ways that we create invalidating environments, and a behavior analyst could probably spend a good amount of time looking at that in any given single situation. So, where can you intervene? First thing is, I would suggest you get an individualized specialty assessment of some sort from somebody to clarify a working diagnosis and provide a basis to clean up the diagnostic pandemonium that will be in these records. Solidify this with a face sheet, and then decide at what interval you're going to clean this chart up again, because it'll happen again. And programs are not able to take these diagnoses off. They're not MDs, they're not PhDs. They can't undiagnose. So the professional evaluation and then the record keeping, this is what you can do, and you can refer to the other diagnoses as historically these things were whatever, but don't have it as their primary, because then they hit the ER with some psych resident who's never met them before and he doesn't know what direction to go in, or she doesn't know what direction to go in. Try to get as much consensus from all levels of care providers, guardians, and supports about the working diagnosis and associated support framework. Add cross systems elements if needed. It's really difficult if you know what you're dealing with, but every time they go to the ER, the guardian is saying, "I've been telling them for months they're schizophrenic and they need medications for these hallucinations that the patient doesn't have." And so then you start all over with this incorrect track of treatment. And again, it keeps the whole the disorder and the splitting and all that sort of stuff that's going on internally in that patient then spreads out into the whole service system, and that person cannot get organized care. If illegal behavior is involved, do not necessarily rapidly dispense with legal or forensic charges. Now, I will say that sometimes law enforcement is ticked off up here and they'll overcharge. So like I had a lady that had a tantrum and tried to run her bus off the road. We actually there was a cage built between her and the driver, but she was strong enough that she ripped the cage and she got hold of the driver and ran the bus off the road. And there were 4 people on the bus and they charged her with 4 counts of attempted homicide. That was a little much. She was mad and she did want to run the bus off the road, but once they're a felony case, they can't come here. And so I wasn't really worried about it because I knew it would take them exactly 5 minutes to figure that out and reduce the charges because they didn't want to keep her in jail. But they sometimes will undercharge too. I'm dealing with a situation right now where a gentleman with a 47 IQ, fairly aware, got angry with a staff member, said, "I'm going to kill you," threw her into the floor, straddled her, and used a 2-handed choke. And it took 2 other staff members literally beating on him and dragging him off to save her life. They didn't charge him with anything.
Getting
And so I'm
someone
in a little bit of a
that you
bind.
don't have a special relationship with on you right size their response is one of the most difficult
Yeah.
things to accomplish.
But basically our patients have to learn, and law enforcement and caregivers and everything, that their right swing that fist ends where somebody else's nose starts. So there has to be some legal involvement, or at least some potential structure when somebody is doing something by choice is kind of loaded, but when they have the ability to regulate that behavior and they choose not to. You know, if they're running at you because they think you are Satan and you're trying to kill them and they're talking to their voices the whole time they're coming, that's a totally different issue. Then I am mad at you. You did not give me what I wanted, so I'm going to kick your butt. You know, one is assault, the other isn't. Well, I mean, it's still assault, but one is legally competent assault and the other one isn't. So how to work those things out is tricky. And a lot of times dependent on the location you are and what resources that you have, but you have to come up with some framework for that. I do think DBT informed framework is important. Um, I do think that skill system is a good tool, works down to about IQ of 45. I had one successful behavior plan and cross systems plan for somebody whose measured IQ is 48. So I mean, we've done pretty well with getting skill system involved. DBT informed care does recognize 3 categories: life-threatening, therapy interfering, quality of life interfering. They are not equal in priority, and if you equalize them, that's where you get that problem with your invalidating environment. If life-threatening behavior is present, consider having no other goals but stopping that, and simplify the behavior stuff for your staff until you are past that phase of treatment. You'll lose a lot fewer staff if they're not trying to make ticks on a data card at the same time they're trying to keep somebody from running into traffic. Ignoring is not an effective strategy at any level for this population. If you ignore something, they will just up the ante until they can't be ignored. So you will buy the next level of behavior if you try ignoring. It's a communication, a desperate emotional need in the moment, or a very well entrenched behavior. It will not be ignored. So I would suggest if you've got ignore this or ignore that in your behavior plan for these people, you go weed it out. Talk to your behaviorist. Consider not putting that in there. And realize and hopefully train the staff to understand the patient likely doesn't want to feel the way they're feeling any more than you want them to. But they hold on to those old strategies and behaviors because they get immediate relief and it works for them. So the only real way to undo it is to make it not work for them anymore and to give them other stuff that does. I really emphasize skill system as a replacement behavior. A self-management tool. It's not really your behavior plan. It's what you give them to do instead of the thing you don't want them to do. DBT consultants can help. I found real success with the ones who work with teenagers because teenagers' level of freedom and regulation is similar to our population. And regular DBT, you're just, if patient chooses to self-harm, you don't necessarily disrupt that. But in, you know, working with our population, working with teenagers, you don't have that choice. So that's why I found the adolescent consultants to have a little bit better understanding of what we're dealing with. And DBT supports, again, are not at odds with ABA style supports because ABA style supports are really going to come into play, especially with the lifestyle interfering behavior. Down the road is going to be very necessary to get involved there. But a dysregulated individual may need more structure than those types of supports can provide, at least initially. Finally, don't try to force normalize somebody's behavior unless you've accounted for the extinction burst. Because if you've got a suicidal patient or a cutting patient and you make that behavior not work for them, the first thing they're going to do is try it harder. And some people's behavior, the environment or their health or whatever could not tolerate that. And so you have to have some different strategies or you have to staff it so that you can be absolutely sure they're not going to cut themselves or whatever it is that they're doing. Again, my corollary there is dead patients make poor behavioral modification candidates. And consider that patient too, what's going to happen when you rip their primary coping skill away and they don't have anything to do yet. So no, you don't want to let them cut themselves. But if you just take that behavior and you don't rapidly train something else, you can get an absolute fall apart emotionally into a pretty severe depressive episode, a collapse, you know, behaviorally, or just some catatonia even, if they don't have anything to help with that emotional pain that they're relieving by doing that. And tackle the PRN medication dilemma head on and early in the process so that people don't have to suffer, both the patients and your staff. But again, looking back here, they need a little bridge. And I know PRNs are difficult, but can be done with the appropriate documentation and the appropriate wording in the PRN. And that has to be tackled way early in this because you're going to need them.
It's a circumstance where I think that PRNs or stat medications could be used effectively with people as long as they're not overused. And there actually is a system that we've contracted with called Station MD. It's a telehealth service for people with IDD, where a primary psychiatric provider has identified and included within a crisis plan an approach to providing medication for a person in crisis. That Station MD could help facilitate that. It's a service that's available 24/7. So, that may be of some value for some people in being able to implement that, because otherwise we require that the agency have a nurse that administers it, which is not available to every agency.
You can check all the way up in your regs too, but we've kind of vetted it out at the federal level here that depending on how it's written, non-nursing staff can give it, but it has to be written in such, not injections, but like an oral medication.
Right.
If it's written in such a way that the non-licensed staff does not have to make a decision.
Right.
So like patient is exhibiting X behavior for 15 minutes with the following, it's like very specific. Sort of like with it's the same issue, like if it's a blood pressure problem or a blood sugar, if blood sugar exceeds this value, administer this. If it's written clearly in that way with no vagueness, you can do it. But the injections, yeah, that's a different issue. And that's where we've had some help from our local hospitals, and each resource setting is different. But we had one patient that was, every time he threw a fit, it'd bust out of the place he was living and go next door to the dollar store and bust stuff up in the dollar store. So the dollar store and the police came to the table, and it ended up that the police got an order from a judge to be able to transport him in a non-emergency way to the hospital to get an injection when he reached that level of agitation before stuff got busted up. So basically he would stand outside the dollar store in our intermediate phase screaming for the police, and that worked out reasonably well. And then we gradually got to where we didn't go to the dollar store and bust stuff up. So it was just approximations. But again, whatever the hurdle is, there's going to be something in your head that's this is impossible or that's impossible. Then go at that impossible thing if you have no choice but to manage that patient, because eventually you're going to have these options.
Well, listen, this has been great. Thank you so much for coming and doing this for us today. I mean, you're fascinating to listen to, and you've had so much experience with all of this. It's just great to hear from you, and great to hear how the cross system stuff is working so well for you up in Kentucky. That's what we want to have here as well. And I think a lot of the suggestions that you've made are just capital suggestions for working with people with borderline personality disorder, other personality disorders. And so thank you so much for being here.
Anybody have any questions, they feel free to email me if they want. So
yeah. So can we share your email address? Is that okay?
I was trying to figure out how to do that. Hold on a second. I'll give
You
you
want,
my,
if you put it in the chat box down there, that would be one thing.
my work email address, so you don't have to be like poor Mr. Wombo and stalk me down off my writing website, because sometimes those emails don't come through as fast. So. All righty. Anything else? Or?
No, that's it. I appreciate you being here. This is the Clinical Consultation Network. We do this every Tuesday at 12:30. Sometimes we do it on a different day of the week, but we'll let you know if that's the case. And Dr. Vaught, please feel free to join us anytime. We'd love to have you again. Thanks. And thank you, everybody, for being here. We'll catch you again next week.
All right. Bye-bye.